All right, everyone. Well, thank you so much for being here. My name is Nicole Hemmenway, and I am the CEO of the U.S. Pain Foundation. And we are so excited to have you join us this afternoon to talk about the patient-provider relationship that is under stress and what we can do to improve it. As you know, this is a two-part webinar series. So today we're going to be focusing our discussion on the problem. Next slide, please. So before we get started, I want to share our agenda for this afternoon. After discussing a few general items, we will start by looking at this month's efforts that US Pain has put out regarding Pain Awareness Month. From there, I'll dive into the findings from the organization's recent nationwide survey, specifically talking about the breakdown between the patient-provider relationship. I'll then introduce our expert panelists. We are honored to have a representative from CMS, Morgan Taylor, as well as two people who live with pain, Julie Litten and David Simpson, join us today. All three are going to share another glimpse of the fractured patient-provider relationship. And finally, we'll turn it over to a Q&A. Next slide, please. Let's look at a few housekeeping items. As I mentioned, questions will be taken at the end. If you are participating through Zoom, you can easily type in your question using the Q&A icon at the bottom of your screen. And if you're joining us through Facebook, type your question into the comments. Finally, know that all of our webinars are recorded, and this will be available for you so that you can watch it at a later date through our website. Next slide. Please note that the information provided today is for educational purposes only. Also, the views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent. Next slide. US Pain would like to thank our sponsors. Our 2022 Pain Awareness Month campaign is made possible through the contribution of our corporate counsel. We thank them for supporting this important initiative. Next slide. All right, so as you all know, September is Pain Awareness Month. And this year, the US Pain Foundation chose the theme of This Is Who We Are to help highlight the real life impact and devastating burden of chronic pain on individuals. Our goal was to show what life with pain looks and feels like to those living with it and how it impacts and affects quality of life. So to accomplish this, our Life with Pain campaign focused on 4 different components: posting daily stats on social media about a key finding in the organization's recent chronic pain survey, which we'll be talking about later, publishing weekly articles on topics that included the landscape of therapeutics, self-management strategies, the prevalence of comorbid conditions, and the caregiver burnout. We challenged the community to share their life with pain experiences throughout the month, and then delving into the fractured patient-provider relationship, which we are doing through this 2-part webinar series. Next slide. Earlier this year, US Pain conducted a survey to better understand the public health crisis of chronic pain. Topics explored include the types of pain, ability to work, patient-provider relationships, treatment options, mental health, and more. 96% of the respondents, or 2,275 people, were individuals that lived with chronic pain. And chronic pain was defined as pain that lasted 3 months or more. Next slide, please. All 50 states, Washington, D.C., Puerto Rico, the Northern Mariana Islands, and the Virgin Islands were represented. By far, the large majority of respondents were female and white, with an average age of 54. Some of these results might be expected. After all, women and older individuals are more likely to experience pain, and women may be more likely to engage with patient organizations, respond to online surveys, or some combination of the two. But that doesn't necessarily account for them being such a significant majority, or the underrepresentation of people of color. The underrepresentation of key ethnic and racial groups, along with underrepresentation of men, are important limitations to keep in mind within the survey results. But one item we found very promising was that 96.5% of respondents reported having some kind of insurance. Roughly half indicated having Medicare, followed by insurance through their employer coverage at 37%. 17% reported Medicaid. When asked about employment, almost half reported receiving some type of formal disability-related compensation. So that could be Social Security disability insurance, workers' compensation, or Veterans Affairs disability compensation. Next slide, please. The findings from this survey really align with what we as an organization hear every day. So one, chronic pain has devastating consequences on function, quality of life, and mental health. Two, at best, people with pain feel their healthcare providers are not equipped to manage their pain effectively. But at worst, people with pain feel unsupported and stigmatized. Three, medications still remain the most effective treatment option, but people with pain face significant barriers accessing certain drugs. Next, due to high out-of-pocket costs, coupled with pain's drastic impact on the ability to work, cost remains the primary barrier to pain care. And finally, multidisciplinary approaches, particularly self-management techniques, are under-recognized components of effective pain management. Next slide, please. Okay, so before we tackle the fractured relationship between patients and providers, I want to take a minute to highlight the severity of pain and disability amongst our respondents. Nearly all said that pain has restricted their ability to engage in routine activities. The most commonly impacted activities were exercise and sports, household chores, or sleeping. A significant portion said that they considered themselves to be disabled, and more than half of respondents reported having an average pain level of 7 or more. One question asked was if there was any side effects that would prevent somebody from taking a medication. And we listed very serious side effects, such as liver damage, kidney damage, or trouble breathing. A total of 24% said no. No side effect would preclude them from using a medication if it helped their pain. So clearly, people with pain are desperate for relief, and they're open to whatever options are available to them. And while conditions varied widely, a commonality was the prevalence of comorbidities. There was only 5% of respondents that reported having just one condition. And in fact, 30% of respondents reported living with 6 to 10 conditions. These enormous figures further underscore the complexity of this health population and the need for better coordination of care. These folks are living with high impact pain, which substantially impedes participation in day-to-day life. They are among the most vulnerable in the healthcare system and in need of a strong, positive patient-provider relationship to help them better oversee their care. Yet our findings continue to show that for the majority of them, this is not happening. The relationship is either broken, damaged, or worse, it's non-existent. Next slide, please. As an organization that provides support groups, we were interested in the intersection between chronic pain and mental health. What we found was that 79% feel stigmatized because of pain. Respondents reported feeling stigmatized the most from society at 72%, but this number was followed shortly behind by healthcare professionals at 63%, and then health insurance companies at 60%. And while 60% said they feel anxiety-like symptoms daily or a few times a week, and 59% said they feel depression-like symptoms daily or a few times a week, sadly, respondents reported that 38% of their healthcare professionals do not ask about their mental health or if they are experiencing feelings of anxiety or depression. Again, these figures should raise alarm. Individuals with high impact chronic pain face so much suffering. They are amongst the most vulnerable patients in our healthcare system, and their physical and emotional needs are not being addressed. Next slide, please. So let's look at how people living with pain view the patient-provider relationship. To start, the number of patients who regularly see primary care physicians emphasizes the vital need for PCPs to be well-trained in pain management, and that is not often the case. Further, when we asked about the appointment frequency, the most common answer was every other month or quarterly. Again, this is surprising given the severity of pain experienced by these individuals, and it reiterates a possible disengagement from the healthcare system amongst people with pain. Another troubling figure, given the severity of pain experienced by this population, was that 19% of respondents said they currently were not seeing any healthcare professional for pain. Why? Well, the most common reason by far was that respondents don't feel supported by their providers. Other reasons that were given were stigmatization, lack of access nearby, and cost. Next slide, please. So I know I mentioned this stat earlier, but I do believe it is worth noting again that 63% of respondents feel stigmatized by their providers. In addition, only a little more than a third of respondents said that they have high trust in their provider's ability to manage their pain. And further, when we asked if they were hopeful that they would achieve the goals of their pain management plan, 36% said no. By and large, patients report that core competencies expected of providers treating pain were significantly lacking. And we're going to discuss this in more detail on the next slide. But these are some startling figures. Validation, patient-centered care, empathy, compassion, and a team approach are really foundational components and fundamental components of an effective pain management plan. And they are not happening right now. People with chronic pain are not receiving the care they need or deserve. Next slide, please. So what are core competencies? Well, this means identifying pain treatment options, demonstrating empathy and compassion, assessing patient preferences, demonstrating inclusion of patients in the pain care decision-making, and so many other components. So when looking at the core competencies expected of providers treating pain from a patient perspective, 53% said their current provider doesn't or only sometimes helps them understand different options for managing pain. 47% said they do not sometimes or rarely feel comfortable discussing new treatment options that they've learned about through other outlets, such as informative healthcare webinars, nonprofit organizations, or internet searches. They do not feel comfortable discussing these options with their current provider. Now, whether because of a lack of time, resources, or training, providers aren't helping patients understand different options for managing their pain. And patients also do not feel comfortable bringing up new pain management options they heard of with their provider. This is greatly concerning when we look at the fraught patient-provider relationship. How do we expect improved health outcomes if we aren't providing or receiving optimal care? Next slide, please. From building a positive patient-provider relationship, much more must be done. 59% said their current provider doesn't, sometimes, or rarely listens to and validates their concerns. 69% said they do not only sometimes or rarely feel like they are a team with their current provider when it comes to managing chronic pain. The fractured patient-provider relationship is causing unnecessary stress. Patients do not feel heard, believed, or supported by their healthcare professionals. They are receiving suboptimal, fragmented care. Recognizing the severity and the vulnerability of these individuals who are enduring disabling, crippling pain, you would hope and expect there would be a strong foundation of trust between the patient and provider, a relationship that was validating, supporting, focused on finding options to best manage their pain together. But looking at these figures, we are far from that model of care. There is dissatisfaction with current traditional pain care that must be addressed for both the patient's and the provider's sake. Next slide, please. So by and large, this survey clearly underscores the enormous gap in patient care and the patient-provider relationship. We have several recommendations for a path forward. First, we must increase pain education for healthcare professionals. Next, we need to invest more dollars into research on safe, effective treatments for chronic pain. And then we must implement a public awareness campaign about chronic pain to reduce stigma. The stigma faced by people with pain is tragic, and it's completely preventable. Myths perpetuate that people with pain are dramatic, lazy, or drug-seeking, instead of looking at us as humans suffering from horrific, debilitating conditions and injuries who are in need of help. This stigma significantly impedes the care and the support that they're receiving, which, as we've discussed, is scarce to begin with. So our hope is that a public awareness campaign would undoubtedly help improve quality of life for millions of Americans living with chronic pain. So now that we have sort of addressed the concerns and the problems, and I've looked at some ways and solutions to improve it, where do we go from here? We can't do this alone. It really is going to require all hands on deck, from policymakers, from providers, from researchers, caregivers, industry members, employers, and teachers and advocates to come together to create a much needed, long overdue conversation that leads to positive change for people with pain. Next slide, please. So now I want to turn the stage over to our expert panelists who are going to add even more insight into that plight of the fraught patient-provider relationship. Next slide. Morgan Taylor has been with the Centers for Medicare and Medicaid Services, otherwise known as CMS, for over 8 years. CMS is a government organization in the Department of Health and Human Services. Her current role is technical advisor and human-centered design lead of the customer-focused research group. This group led the chronic pain human-centered design engagement, which led to the creation of the CMS Chronic Pain Journey Map, which she is going to be speaking about today. So please join me in welcoming Morgan. Morgan, thank you so much for being here with us today.
Hello, everyone, and thank you, Nicole, so much for the warm introduction. And just a big thank you to the U.S. Pain Foundation for putting on such a wonderful and inspiring event. I'm really honored to be invited here today to share our chronic pain customer engagement work completed at CMS. And as Nicole said, my name is Morgan Taylor, and I'm just honored and thrilled to be able to spend some time with you all this afternoon. Okay, so I will start by saying...
Do you need the next slide?
Oh, yes, I'm sorry. Next slide, please. Thank you. So the Customer Focused Research Group, in partnership with our Center for Clinical Standards and Quality at CMS, launched a stakeholder engagement in late 2019, which focused on understanding access to covered care and services for people with chronic pain. So CMS really wanted to understand more about what the experience is like for those living with chronic pain and seeking care under our programs. Our team used qualitative research methods and the human-centered design process to understand and visualize the customer experience, uncover burden, and identify opportunities for improvement. Next slide, please. So here is our handy dandy infographic. This work was really done in collaboration also with the Center for Disease Control and Prevention, or CDC, as many of you may know it. Something really awesome that I'd like to highlight is in the fall of 2019, prior to us starting our engagement and our work, our CFRG team flew down to Atlanta to assist the lab at OPM with the launch of the CDC's Human-Centered Design Engagement, which was ultimately seeking stakeholder input on their 2016 opioid prescribing guideline. Hopefully some of you are familiar with that. And because of this partnership, we were able to leverage the CDC's stakeholder interviews and some of their RF requests for information comments, as well as, interviews we conducted ourselves. So our team spent many months talking to folks living with chronic pain, as well as those treating people with chronic pain. And as you can see in this infographic, our interviews, our RFI comments, and listening sessions led to over 7,200 unique data points. And this is data including data from many different perspectives. Again, people with pain, caregivers, providers, etc. And just as a note, we have been doing customer engagements in many different subject areas since 2017, and this is by far our largest data set ever. So I think that says a lot in just the amount that we heard of, we really need to listen in this area and try and make meaningful changes. So I just want to highlight that for reference. During our synthesis process of the data we did gather, 5 opportunity areas we heard from our stakeholders really arose. And it's our job. It is coming from their perspective, their lived experiences that we will share. And it is our job to carry their voices forward and provide CMS leadership with actionable insights that give opportunities to make those we serve lives better. So I will dive into our 5 opportunity areas a little more. You will see them listed on the top right-hand corner of this slide. So our first opportunity area is recognizing people dependent on opioids from people with opioid use disorder. The stigma is real. Due to long-standing improper use and distribution of opioids, many individuals have developed opioid use disorder and present with drug-seeking behaviors, such as street purchasing or manipulating providers to prescribe for a fix. This ultimately results in being labeled as a criminal, which is often equated with choosing immoral or criminal actions as a lifestyle. This bias is pervasive and stigmatizes all who use opioids as bad and renders their chronic pain invalid. When a person with chronic pain needs opioids for relief, they are often subjected to access barriers and mistreatment due to stereotyping from providers. Our second opportunity area is expanding and extending coverage and services. When people with chronic pain discover a treatment and/or medication that alleviates their pain, but is not covered adequately by their insurance plan, those who can afford to may pay out of pocket, while those who cannot go without treatment or medication. Some indicate that the expenses are higher because they had to change to a pain specialist or due to the strict guidelines on the frequency of doctor visits and the regular cadence of drug testing. Many people with chronic pain want to move away from opioids and utilize less addictive alternative treatments. But several of these options are not approved or covered by insurance. Behavioral health services, acupuncture for fibromyalgia, not enough covered physical therapy sessions, aquatherapy, psychological interventions, chiropractic medicine, just to name a few. And social determinants such as where someone lives, their employment status, access to exercise, and good food options, all impact a person's ability to holistically treat their chronic pain. Treating the whole person for chronic pain management includes socially, mentally, and financially. It is truly a 360-degree holistic approach. Our third opportunity area is alleviating provider fear and unease. Finding a provider brave enough to treat them is a common plight of the person with chronic pain. Providers have demonstrated that taking on people with chronic pain who need opioid interventions frightens them, as it puts them at risk of being scrutinized by punitive entities they would rather avoid. Instead, some providers have opted out of taking on people with chronic pain in their practice to circumvent any controversy that may occur during their care. This results in care being delayed purely by the sourcing process. People with chronic pain must do their own research and sometimes travel long distances to multiple initial visits until they find someone that will take them on. Due to increased pressure, providers are losing their autonomy to prescribe pain medications based on their clinical judgment and long-established rapport with people with chronic pain. Our fourth opportunity area is covering the extra work. Treatment for people with chronic pain is not a linear, straightforward process. It takes great time and energy for providers and patients to develop, test, and finalize an effective care plan that fits specific needs, access limitations, and comorbidities. Currently, providers feel they do not have enough time allotted to give this individualized level of care as they work to balance their entire patient panel and competing responsibilities. Compounding this, some providers feel they're inadequately educated to treat chronic pain. Developing this skill takes time to learn and hone. For these reasons, many providers opt out of treating people with chronic pain and refer them to external pain specialists to save time and space in their own clinics. Ultimately, this results in an access issue for people with chronic pain as they wait long periods of time to see a pain specialist or must travel long distances to see a provider willing and able to treat them. Our last opportunity area is adopting guideline flexibility. People with chronic pain repeatedly advocate for themselves so their pain will be taken seriously and sufficiently treated. Since the CDC opioid prescribing guideline were implemented in 2016, people with chronic pain feel providers no longer have the capacity to develop individualized treatment plans nor prioritize their comfort and quality of life. Of course, providers care about their patients, but are pinned beneath an inflexible algorithm used by insurance companies, federal enforcers, and medical boards to ensure the CDC recommendations are being followed. These competing desires and capacities have resulted in distrust from people with chronic pain that dissolves faith in their providers, their health plans, and ultimately their government. In February of this year, 2022, CDC proposed a new guideline for prescribing opioids used to treat chronic pain. The guideline, which is still in draft form, removes previous recommended ceiling for opioid dosage and guidance that was met with backlash at the time, which we heard a lot about in our research. It's also important to note that while the guidelines are technically just recommendations, they tend to influence insurance coverage and even state law. Next slide, please. So lastly, and perhaps maybe the main reason I am here today, but we would like to share with you the illustration in which we co-created with many of the stakeholders we talked with as part of our research that focuses on the experience of experiences of those living with and treating chronic pain. Its primary intent is to highlight the most prominent barriers to people accessing care and the influencers on providers, ultimately affecting the person with chronic pain, their quality of care, and their quality of life. There is no one-size-fits-all way to treat people with chronic pain, and it is important to take different approaches and individualize their treatment options. As we look at this illustration, remember the perspective is from those living with and treating chronic pain. Of note, the lightning bolts represent a person with chronic pain. Starting on the left-hand side, people with chronic pain cannot find a provider that will take them. And when they do find one, they realize they have insufficient insurance coverage for care, which includes services and medications. The person with pain at the bottom of the page is not only feeling the weight of the chronic pain experience, but is looking up, feeling overwhelmed and wondering, how am I going to do this? A person is attempting to climb, but is dodging the stigma barriers of having chronic pain. Toward the middle, you will see providers opting out of treating people with chronic pain. Family and caregivers feeling lost, they do not know how to help. And ultimately, the person with chronic pain is walking a tightrope daily, juggling and trying to balance their work and day-to-day tasks, their mental health, their quality of life, and feeling the financial burden of their treatment options not being covered by their insurance. The weight of the punitive regulatory environment literally pulling on them, making them unsteady, and balancing all this daily is incredibly tricky. The person with chronic pain is barely holding on, feeling at any moment they could fall to the ground without any safety net to save them. On the right-hand side, you'll see there is complementary and integrative care options. However, the person with chronic pain does not have insurance coverage for those care options. So they must decide on whether they can afford to pay out of pocket, and weighing, do they get groceries to feed their family or get care to relieve their chronic pain? Many people with chronic pain take care into their own hands, and some with substance use disorder are not connected to ongoing care and feel alone and unable to move. This illustration, hopefully, people can see themselves in it. It is not, the most glamorous, but it is what's really happening in the chronic pain community. And so we at CMS are doing our very best to understand the experience and do our best to find ways to make it better for those that we serve. This does conclude my segment. I will turn it back over to Nicole, and I look forward to answering questions at the very end. And thank you all again for your time and attention. I really appreciate it.
Thank you so much, Morgan, for going over how the journey map came about and also just talking us through the map itself. I think you did such a great job at really listening to the patient perspective and showing the realness of the chronic pain experience. I appreciate it. Thank you so much. Next slide, please. So now I am going to introduce our next presenter. Julie is a retired physician assistant whose chronic pain started in 2010 with a series of herniated and bulging discs. Despite her medical background, finding coordination of care, access to needed treatments, and doctors to validate and believe her pain has been a long and trying journey. Today, Julie is a co-facilitator of a chronic pain support group for people living in the state of Maryland. And she continues to help advocate for others that are also living with chronic pain. So Julie, we are so happy to have you here. Welcome. And I'm going to turn the stage over to you.
Can you see me?
Yes, I can. I had muted myself, so I had to
Okay.
unmute myself quickly. Yes.
Okay, great.
Thank you.
Thank you so much, Nicole, and also Cindy Steinberg from US Pain Foundation. And I just want to thank you, Morgan. You gave part of my talk. The way you explained the journey map was very moving, and I can relate to a lot of it. So, how many of you have heard words from your doctors or other providers like these or similar things? Your pain is probably psychosomatic. You probably already had those herniated discs before now, even though your MRI shows them documented. 50% of people with herniated discs on an MRI don't have pain, okay? So what about the other 50%? That's a huge number. Your neck pain is most likely musculoskeletal, not from your herniated disc. Here's a prescription for physical therapy for your myofascial cervicothoracic pain. And by the way, it didn't help at all. Another provider. These were the first questions from a particular doctor. Quote, "Are you here because you were in a motor vehicle accident or an on-the-job accident? Is this a legal case?" Needless to say, I never went back to that doctor. From behavioral health. Quote, "We're referring you to a 30-day inpatient rehab facility for your, quote, chemical dependency." That's the old school term for addiction or substance use disorder. I was at the time taking legitimately prescribed prescriptions, taking them the way they were prescribed. I refused to go. I didn't have chemical dependency or any other problem. I just wanted my pain to end. And last but not least, from an emergency room physician. "Don't ever come back to my emergency room for your chronic pain or anxiety." For real. These words and many more were said to me at the beginning and for years into my chronic pain journey. They caused me to feel stigmatized at a time when I needed help the most. And to this day, I still feel that sting when I write down all my medications, especially at a new doctor's office, you know, on the healthcare form, and wonder, what are they thinking of me? Or if I go to the pharmacy and I deal with the pharmacy staff, what are they thinking of me? I don't really talk about my chronic pain to anyone outside of my closest family and friends, or the people that I know who also have chronic pain. So like Nicole said, my chronic pain started in 2010 with a series of relatively minor things. There was a big snowstorm. I had to leave my house on very bumpy, icy roads. When I came home, my dog wanted me to pick him up, so I deadlifted him. And I had terrible pain in my lower back that went down my leg. Now, I've had low back pain before, but this was not the same. I never had pain that lasted for months and months and months. So the acute pain turned to chronic. I started going to a series of doctors. Some at the very beginning thought I was drug seeking. And these are some of the doctors that I saw. 4 neurosurgeons who evaluated me, but told me that I wasn't a candidate for surgery. And that actually one of them said that surgery could make me worse. then 3 orthopedic spine specialists. A couple of them maybe held out surgery at the very end, but they weren't keen on it. 2 physiatrists and a neurologist. Sounds like a nursery rhyme, right? Lots of ER visits, even a couple of hospitalizations for pain management. So my family actually at the time still thought there was a cure. And secretly I did too, but I was rapidly giving up. So they didn't know what to do. They didn't have the support. My pain was always at that point either untreated or undertreated. And I want to refer to that picture on the journey map. I really related to it. The patient and the doctor in the encounter at the top on the left-hand side, where you see the bubble of their talk, and the intersection is very, very small. So all during this time, I felt like doctors didn't understand me and there was poor communication. Even the bird there is saying like, nevermore, like with Edgar Allan Poe. I like the bird, by the way. So the other thing that was happening at the same time was that my mental health fell off a cliff. I didn't understand at the time that anxiety and or depression can be comorbid with chronic pain, but I didn't understand what was happening to me. My loss of function was profound, and my search for relief was an ongoing thing. And my family, like I said, didn't know what to do. So yes, I was hospitalized. I had clinical depression. I had suicidal ideation. From talking to thousands of people online, I know that I'm not alone. I know so many of you have experienced profound grief and loss through this process. And I actually had no prior history of seeing a psychiatrist or a mental health diagnosis. So it clearly was from the chronic pain. So, good news was after 2 years of struggling, I was accepted at a pain management clinic that was headed by a fellowship trained interventional pain management anesthesiologist. For me, having that kind of high level specialty, a specialist was important. I had to, sign a pain contract and go through at the time, the humiliation of frequent urine drug testing. That continues today, but I guess I've gotten used to it. I had a series of interventional procedures. One helped, the rest didn't. I have had medications of many, many kinds from that, not just that practice, but all different doctors in both physical and behavioral health. Some worked, some didn't, some had side effects. It was a mess. So the other thing that I became aware of thank you for putting up that slide, by the way, in all these doctors and all these experiences. And of course, at the time, I wasn't functioning. I wasn't really able to be a part of the family as I had been, and work was out of the question. I realized that nobody was talking to each other. I love my primary care provider, but she wasn't talking to the pain management doctor. The pain management doctor wasn't talking to the psychiatrist, and so on. So, and that persists today. So we have silos of care where nobody really knows what's going on with all the aspects of the care. The other thing that happened that I noticed was that I was literally told by someone in pain management, not the doctor, but a nurse practitioner and others, we can't help you unless you have your depression taken care of. We can't help your pain. We can't really treat your pain adequately unless you have that taken care of. And the people in behavioral health would say, well, we can't help you until you get your pain fixed. So that was more than frustrating. So it was really up to me to cobble together some kind of care. And so this happened over time, over years, over trial and error. And like I said, lots of different treatments, lots of different medications. At the time, I didn't have the money or the transportation to go to things like acupuncture or other kinds of massage. I did do physical therapy a couple times. It barely helped. So I had to put together my own individualized plan and pull modalities that I learned helped me. Some were medical, some were psychological, and a lot are self-care. Let's see. I think that my life is much better now, and I do feel more balanced, but I know that if anything does happen, that I have more resources and I have more people that I can call on to help me. So that's a really good thing. So now I just want to leave you with a few tips that I wrote down, if I can find them. Sorry. Well, one is to always take someone with you to an appointment. There are a few reasons for that. One is they can record, they can take notes for you, because it's very hard to hear everything that a provider may be saying to you. You might be having a bad day, and so that person can fill in the gaps for you. And also it can help with any bias that the provider may be having towards you as a woman, a person of color, a person that's too young, a person that's too old, et cetera, et cetera. You can go down the list. So if you can, bring a friend or a caregiver with you. Number two, and this took quite a long time for me to get the gumption, but if you don't like your provider, get a second opinion or even a third opinion. Now, I know in pain management that may not be able to happen, because changing providers is a red flag. But I'm talking about the other kinds of doctors that you may need for your co-occurring conditions. Read a lot, learn a lot, find out about your medications, learn about your conditions and your illnesses, and try to learn about health itself. I think that that's been really helpful to me. Never mind my background. I always stay curious. I like to learn whatever I can. 4, as Morgan said about self-care. Self-care is healthcare too. So learning what are good health habits, good nutrition, some movement as you're able, support groups where you can learn coping skills, some kind of meditation or self-calming techniques. There's lots of stuff on the internet. I'm not just telling you that as a platitude. I actually went through all that, hours and hours of looking at videos and reading articles. And then finally, connection. It's been a really rough couple of years. We all need human connection, whether it's from friends and family members who care about us, and also finding people that speak your language, your chronic pain language. I feel so fortunate in finding support groups and now being able to give back by being a co-leader of one of the support groups. And also my online community, there are lots of support groups on Facebook, and I've been a part of them since 2010, and that's really helped me too. So I wish everyone the best. And again, thank you for allowing me to speak.
Julie, thank you so much. Thank you for just being so candid and honest and real about your experiences. And I loved how you tied it in and how it correlated so authentically with the CMS journey map. And for also just sharing these tips and insights. We really do need to find people that understand, and you just said it so articulately. So thank you very much. I truly appreciate you being here with us today. Next slide, please. So now I have the pleasure of introducing David Simpson. David has lived an active life working as a video producer and practicing martial arts. When a single kick one day during a martial arts class prompted years of increasing pain in his back and neck. He was diagnosed with spinal stenosis and eventually needed a spinal fusion surgery. Because of his health insurance, he experienced repeated poor treatments at various clinics, showing him that class is a major factor in how individuals are treated when they go to the doctor. Today, David continues to live with pain, but is using his video production experience to help others in nonprofits. I'm going to turn it over to David. Thank you so much for being here and allowing us this opportunity to share some of the experiences that you have learned. Thank you.
Hi, thank you. Thank you, Nicole and Cindy from US Pain Foundation for inviting me to this event. And I hope that what I can share resonates with someone. So I'm going to start off by reading something. It's rap lyrics from one of my favorite rappers who has a song about physical pain. It's very short. It goes like this. Bad back, bad back, bad back. One half zig while the other half zag. Stand too long and the whole shit hunch. Sit too long and I can't stand up. Gramps out for a Sunday drive. A man is betrayed by his lumbar spine. Who pull up to the spot like, I'll meet y'all outside. I need like 5. Corpse pose, staring at the moon, entirely on fire, sciatica to boot. I'm ready to be turned into soup or shot into space or squashed into cubes. Quote, rate your pain level on a scale of 1 to 10. I said, well, doc, I'll tell you. I feel like I lost a friend. I'm usually okay to simply shut up and cope, but these days, more than ever, my back is like, nope. So that's a song by an artist named Aesop Rock, and the song's name is 1 to 10. So in these verses are a lot of what I've experienced over the last few years. This journey started in about 2008, 2009 with the incident in the martial arts class. And in this, we hear betrayal, feeling betrayed by your own body, anger, resentment, resignation, exasperation, and ultimately loss. My favorite line is, rate your pain level on a scale of 1 to 10. I said, well, doc, I'll tell you, I feel like I lost a friend, which is very indicative of like, what a provider is looking for is some linear quantitative measure of where your pain is at. But what actually is sometimes happening is like emotional. He feels like he lost a friend. And a lot of what I experienced through my journey is this grief and loss for my former self, and the exasperation of thinking that I needed to recapture that or get back to that person, rather than take stock of where I was and where my abilities are, and work from that point forward. So I thought that was really relevant. I'm 43 years old. I live in New York City, in the Bronx. And like Nicole had mentioned, this started in 2008 when I was in a martial arts class. I threw out my lower back, and that began this ripple effect of injury that turned into spinal stenosis. So after that injury, I took some time to recover. I started running to get back into shape before I went back to the martial arts class. And then a few months into running, I started to have severe neck pain. So at the time, I was working at an ad agency. I had very, very good insurance, and I was able to afford really, really good care at the time. And so I went in immediately. They gave me CT scans and MRIs and found that I had the spinal stenosis, and was prescribed physical therapy, and like yoga at a fancy yoga studio, and like private Kundalini breathing exercises, and all sorts of like really high-end treatment, because I worked at this ad agency. It had this great insurance. And I was able to do that for several years while I worked at that agency. But then I left that company and started freelancing. And for many years, I didn't have any insurance. And so it took me about almost 10 years to finally get to a place where I couldn't take the pain anymore. I worked as a producer, and most of my time was spent at a desk managing projects. It wasn't until I came back to New York City in 2014-15 where I'd gotten to a place where I wasn't sleeping anymore. I started to have numbness and tingling in my arms. The pain was constant. At one point, I had to call off a vacation in the middle of the vacation and fly back home because I couldn't stand the pain anymore, and I couldn't be somewhere other than my home at the time. So some of the issues that came up for me were in this process. Well, so I in 2014, 2015, I started looking for a doctor, and the strain of looking for a doctor was incredible. How do I find the right doctor? What experience is required? How do I know that this doctor is the best candidate for this? And the decision-making process and the research required was a full-time job. Finally found a doctor, and found someone who was going to perform a fusion surgery. I had one surgery in 2016, which was a fusion of C5 through C7. And then after that surgery, it took after the point of being at a place where I should be getting better, I wasn't. And I went back to pain management specialists and was continually asking them, what else can I be doing? I was going to physical therapy. I think it was like 2 months after 3 months after the actual surgery, I had ceased taking the pain medication because the fusion should be in a place where I didn't need to take the drugs anymore. And I was continually asking for further help, and no one was advancing my treatment or looking for other options for me. And it wasn't until I was frustrated to the point where I decided I needed to get a second opinion. I decided to find another doctor, and that doctor immediately got me new x-rays and discovered that first fusion surgery had failed. And I had a broken screw in my spine, and that a new surgery had to be performed where they pulled out all the hardware and refused that area. And so it was almost 8 months of living through constant pain, being ignored, and being told that I needed to seek therapy, which, it is actually good advice. Like Linda was mentioning, that a lot of these things require interventions that are psychological, and because pain is so integrated into depression. And so I finally got a second opinion, got the second surgery done, but it was a really long journey of having doctors not believe me and living with a broken screw in my back for months before someone took me seriously and said, you know what, this doesn't make any sense. He's in way too much pain for this term after surgery. And so a lot of what was difficult about that process was realizing that the pain wasn't going to end anytime soon, and that my body, like the instrument that for 40 some odd years up to this point was the thing that allowed me to judge what reality was unreliable, right? Like, my pain wasn't telling me what was real in the world, and so I had to reevaluate what my tools were, and also my language about pain was inconsistent. Like, it was very difficult for me to describe my pain to a doctor or a pain management physician. And so I felt kind of crazy and ashamed that I was experiencing this, but I couldn't really speak it. This idea that rating your pain on this linear scale, and I'm telling my doctor, well, my pain is at a 7 or an 8. But really, I kind of felt like my pain scale was logarithmic. If it increased even slightly, it would put me over the edge. And so rather than, the pain between, 2 and 4 is the same amount of pain between 7 and 8. I don't know if that's clear, but basically, as pain increases, the distance between that numerical value seems to get smaller. And so I didn't really know how to relate those things. And so having conversations with a doctor about my pain was very difficult and often dehumanizing, because you have someone who is supposed to care for you and they're supposed to look out for you, but they're denying your very existence and claims about your condition. So so I think that's really it. I'm trying to look through my notes here. I think one other thing is that when it's been quite a long journey. I spent a long time out of work because I didn't know how to work. I worked really long hours as a producer, working at these agencies and production companies, and I had to reevaluate what it was that my body could do moving forward, and that required me to really take stock of like what my abilities were, and start from zero. And what I would encourage anyone to do is, and I was very lucky. Like, I had a family who was able to support me throughout all of this, and I didn't have to work. I didn't have to pay rent. And a lot of people don't have that luxury. And so I feel that I'm very blessed in that I was able to navigate all of this and not have the financial strain. And so many people are not that lucky. But the one thing that I can say is that, like, if you've ever considered like having a breakdown, go for it. It will, if you, and by that I mean letting everything go so that you can start over, is the only way that I have been able to build myself back up from that place that I was in. And so, yeah, if you're in pain, stop, take care of yourself, lie down, and don't try to push through it, is what I would recommend to everyone. Yeah, I think that's all I have right now.
Thank you so much, David. I truly appreciate your words, and I thought it was so powerful when you started talking about the feeling dehumanized and how pain is a full-time job, and really reevaluating what you can and can't do, and taking stock of what is important to you and what matters, and then finding ways that maybe you can incorporate them in your life. It might be slightly different, but you can still get there. And also, I will definitely be following. Oh, keep going. Yes, what do you have to say?
Yeah, you know what? There's a major piece that I did leave out, and I just remembered that I wanted to touch on. It was that one of the pieces about my care that was very difficult for me to figure out was, in the beginning, looking for doctors. I was asking my insurance company, like, where should I go, right? And in that process, they would send me to these clinic hours where I would find out that doctors and surgeons would sign up to provide care for Medicare patients in these clinics. And I would go to these clinic hours, and I would wait for hours and hours for care. And oftentimes, I, even sitting there in an office waiting for my appointment, I would have my appointment canceled after spending 2.5 hours traveling there, plus the time that I was in there. That happened over and over and over again. And I realized after that had happened many, many times, that the way that I would get better care was to reach out to hospitals or orthopedic offices directly, find out who was providing care for people with Medicare, and then seeing those doctors. But even beyond that is, I had to find hospitals in Manhattan. Like, I couldn't see doctors in the Bronx. I couldn't see doctors in in Harlem. I had to go where there were people with money to get the care that I needed. Like in my neighborhoods, I wasn't getting the care. I was, it was cattle calls of people, 50 people in a room waiting for an orthopedic doctor to see them for 15 minutes. And it literally took, close to a year of this trial and error, figuring out that, I can't see physicians where I'm at. I've got to go where essentially rich people with money go see their doctors. And so that was a really big piece of this, and part of that sort of dehumanizing element of trying to seek care when you're trying to do what's best for you, see a doctor near you, not travel miles and miles to get care, but you often are not given that type of care or the adequate care where I am from. So that's one of the big pieces of my journey that made it so difficult and depressing. So yeah, thank you.
Thank you so much for sharing that. And I am sure just hearing some of the comments that other people can also relate. And hopefully, I don't know if we're going to be able to solve everything today, but I think it's laying the groundwork and starting this conversation is that first step. So thank you all to all of the presenters. I was hoping that each of you can come back on, turn on your screens and potentially unmute yourselves, because we're going to open it up to a Q&A. We have gotten quite a few questions already, and just looking at the time, I think that we're probably going to limit it to about 5, and we'll try to follow up with any questions we didn't get to answer live later on with each of you. So I am going to start actually first with Morgan and ask a question that came in that I found very interesting. And has CMS ever thought of educating healthcare professionals around pain management and offering pain management training?
So I think, and I will just note that my group does not oversee policy at CMS. So I want to set the groundwork there that we do a lot of the on the ground research to hear what's going on, to then take it to the folks at CMS who do oversee policy. And that has been 1000% part of our discussion. Once we've uncovered that is a major barrier that we're hearing, both from patients saying, I don't think my doctor knows anything about how to treat someone with pain. And then, we did hear a sprinkling from providers saying that they didn't feel equipped enough to really understand and treat, and that wasn't, enough part of their education. So we are having those discussions around how can that be pushed through the best way. Is that in medical school? Is that in continuous learning? Is that different avenues to explore? So if whoever asked the question has any specific recommendations for us to consider, would absolutely love to hear them. But education is a huge part of what we've heard, and seems like an easy way for us to reach more, as we provide education on a lot of different fronts. So why not in this space? So I agree with the question, Nicole, and thanks for whoever asked it.
Great, well, thank you. And I'm sure a follow-up question they're going to ask is how do they reach out to CMS to ask about further education?
That is a good question. I would offer myself as a starting point, but I can get I know we have channels for questions of that nature, but I guess we're asking if a provider wanted to receive more education. Is that what I'm hearing? Or a patient?
Well, I think it was probably the patients wanting to know if there would be more provider pain education available through CMS.
Okay. Yes. Well, again, I think that's something that we're trying to figure out the best channels to go through. We have a lot of open door forums and things that are ongoing all the time, but perhaps it's needs to be more regular or available at any point in time. So definitely appreciate it.
Thank you. The next question that I wanted to ask is going to be directed toward Julie. First of all, a big thanks to both Julie and David. The individuals that are tuning in, just keep saying thank you for being so candid. It really helps validate what they are going through, and it empowers them on their own journeys as well. But Julie, this question is for you, and it is around support groups that you mentioned. How has participating in support groups helped you in your struggles to deal with chronic pain?
Well, I would say it's multifaceted. I started out in a support group way back in, I'd say 2011, when Pain Connection was a local nonprofit organization led by Gwen Herman, who is now under the U.S. Pain Foundation. So the big thing for me was actually they were in person, being in a room where people spoke the same language, were not critical or doubting my story. I got to tell my story. We understood each other, even if our pain conditions and illnesses were different. So that was the first thing. And that was something new and very healing to me. The second thing is that I ended up, going on to the evolution of the Pain Connection support groups, which became monthly. And then, of course, now we've been on Zoom. And I learned a lot of coping skills. I learned about pacing. I learned about how to deal with family stress, how to deal with holiday stress, and got to engage in discussions with people in the support group. And then, of course, eventually, I was asked to co-facilitate a group and went through the training through Pain Connection under U.S. Pain Foundation. And that helped give me purpose. And that is also a wonderful thing too. It's a volunteer job that I am able to do. So thank you for the question.
Thank you, Julie. David, a question that came in for you was around your experiences and if any of your pain became neuropathic pain in nature. And if so, how has that process been for you, and have you found treatments to help?
Yeah, so the bulk of the pain is actually neuropathic, and so it's been helped with medication. So I take gabapentin for that, and that actually does help me sleep. And in terms of the thing that has been most effective for me is staying as active as possible. It's weird because it actually doesn't reduce the amount of pain I feel, but the effect of feeling stronger helps my mood. It helps me feel better about myself, and that in turn helps me cope better. I wouldn't say that like getting fit and working out will reduce the amount of pain you feel, but feeling like a stronger human helps me feel better about life, and that's kind of the only suggestion I can make there.
Perfect, thank you. Morgan, another question that I had for you was, will CMS consider covering more complementary options for pain?
Yes, it is definitely, we're trying to make as much progress as we can, and as fast as we can, and hearing about what people want is really helpful in helping us determine what paths to go down. I can't remember exactly when it was, but when Medicare came out with their coverage of acupuncture for lower back pain, that was hopefully received well in, and I know that's a very specific form of care or service, but it's things like that where we get very targeted, specific recommendations that we can help, focus our attention in a certain way. But absolutely, we want to try and expand our coverage, and would really love any, again, specific recommendations for us to consider. That's how we can make the most meaningful change possible.
Perfect. Thank you. Another question, I'm going to start with you, Morgan, and then David and Julie, please feel free to chime in as well. But how do we get policymakers to understand that there's a significant difference between addiction and chronic pain? And why do you think that these two are so conflated together by policymakers?
Yeah, it's a brilliant question. And I think a lot of the work we've done with our chronic pain engagement is helping to get this message to as many people as possible within CMS, external to CMS, in the legislative, community. We want as many people to understand the distinct differences that are true. And, I think there's a lot of social, external, happenings that have affected the space in a totally negative way. And we're swinging way far than the other way. And we need to, recorrect ourselves, because it is a extremely effective form of pain management for some people. And we need to make sure we're totally understanding the difference between, the two paths, or 3 paths, 4 paths. We need to do a better job. And again, we're doing our best effort to get as many people showing up to places like this and sending, putting forth our message and trying to reach as many people as possible in the policymaking community, as well as, the patient community, to show that we really are trying and we really are listening.
Thank you. That is such great information. And we are all working for that. We're all working toward that same goal, for sure. Julie and David, did you have anything that you might want to add? And I see that we're running close to time.
I'll say something.
Yeah.
Which one?
Julie, go ahead.
You can start, Julie.
Okay. So, the thing that both populations have in common is a class of medications, which are scheduled. They're controlled medications. They're under the DEA, the Drug Enforcement Agency. Doctors and other providers have to do something special to get access to prescribing these medications. But even though we are doing this, we are taking the medication for a different purpose. And I'll speak for myself. What I take is prescribed. It's a matter of the public not understanding, the medical community not understanding, and policymakers not understanding what is chronic pain. What is the benefit for a certain part of the population with chronic pain who have intractable or high impact pain, who need this medication as kind of a basis for everything else. It doesn't mean that's the only thing that we do. So I agree, more education, telling our stories. I've had the good fortune of being on a panel of patients and caregivers at Johns Hopkins University Medical School for their first year med students as part of a mini class on chronic pain. Showing up like that, exposure to who we are as people. I think it all helps.
Absolutely.
Yeah, the only thing that I would note is that, my experience of having chronic pain makes me feel like my body and brain is just so different from what it used to be. Like, we have acute pain conditions that we know are to end, and after you start having chronic pain, your physiology is different, and the way you process is different. And so there is a gap between what I think physicians expect to happen, and I think that's important, and more research needs to be done in around that. And I don't know what it would take to bridge that gap and understand how people with chronic pain differ from quote unquote normal people. But it's certainly evident in how doctors speak to you about your pain, and you can tell when you're speaking to a doctor that hasn't had that happen to them. So I think that's a big piece as well.
Well, thank you all so very much. Thank you again, just to our panelists today for being here. You were fantastic. Thank you for participating, for giving of your time, and for candidly sharing your own perspectives. You've just helped validate the patient experiences and shed such light on a significant problem that is affecting millions of patients and providers nationwide. I truly appreciate all of your time today and your expertise. I do know that we didn't get to everybody's questions. I'm so sorry, but we are running out of time. We will try to stay on and answer as many of them as we can. But next slide, please. So as a reminder, this Thursday is going to conclude this two-part webinar series, and we are going to be looking toward solutions. So please join Director of Policy and Advocacy for U.S. Pain Foundation, Cindy Steinberg, and an amazing panel that includes Dr. Scott Lawrence, who is the Deputy Director for the Division of Practitioner Services in the Center for Medicare at CMS, Dr. Scott Fishman, who is the Chief of the Division of Pain Medicine at UC Davis, and Dr. Dave Nagel, who is a physiatrist specializing in pain management for over 30 years. Together, they are going to come and discuss ways that we can improve the current fraught relationship between patients and providers. For those that would like more information regarding our survey and the findings report, I invite you to download the complete report at the site listed on the slide. And then please know that this webinar has been recorded and will be available in the next coming days on our website. So you can always come back, rewatch it, share it with others. And then on behalf of U.S. Pain Foundation, we just want to say that you are not alone on your journey. We have different resources and services to help you. So please find out more ways that you can get involved and more ways that we can provide help and resources by visiting uspainfoundation.org. Again, thank you to our panelists. Thank you again for everybody who tuned in and is watching. We look forward to seeing you next Thursday when we look at some of the solutions to what we discussed today. Until then, have a great afternoon and take care of yourselves. Bye.
Thank you.